Ibrutinib and the other BTK inhibitors, fortunately, are very well tolerated in most cases. And if you look at the data, especially in CLL, as well as mantle cell lymphoma and other disease histologies, you can see that a large number of patients are able to stay on treatment for a very long time. Having said that, there are a number of key toxicities that everyone needs to be aware of, both that can be mild but annoying over time, and others that can be life-threatening. So ibrutinib in particular has been associated with life-threatening bleeding complications. This does not mean that a patient cannot be on anticoagulation at the same time, but certainly those are patients that you need to really think carefully about whether or not it's appropriate for them to be on ibrutinib, or if they may be a patient that could potentially discontinue the anticoagulation. But we do know that patients that are receiving ibrutinib ideally would hold the ibrutinib before any surgical procedures, and certainly if they were to be in a car accident or have any other trauma, would be at an increased risk for bleeding. In addition, we know that ibrutinib can be associated with an increased risk of atrial fibrillation. And given the fact that frequently it's administered to patients in their 60s or 70s at a time when AFib and other cardiac complications tend to emerge anyway, it does require close observation. Some less severe but also important toxicities can include arthralgias, hypertension, as well as diarrhea and rash. And these are things that may not necessarily require a patient to discontinue the medicine, but you can imagine having even mild diarrhea over a long period of time can really be problematic. So it's at least important to mention it to patients so that they can feel comfortable bringing it up if it were to happen to them. And then finally, although this is not chemotherapy per se, there have certainly been some increased risks of infections for patients that have been on ibrutinib. I tend to incorporate antimicrobial prophylaxis with antivirals as well as with Bactrim when feasible for patients that are receiving ibrutinib. But it's important that patients recognize that although they are not receiving traditional chemotherapy, they are at increased risk for infectious complications, so that this does need to be monitored. And then finally, I would also point out that although not a physical toxicity, that there can be some significant costs associated with ibrutinib, and patients are sometimes not overly enthusiastic about sharing this concern. At our own center, and I'm sure at a lot of your centers, there are folks that are available to help with patient assistance programs, and the companies themselves have a number of opportunities to help make it more feasible for patients to obtain the medication over a long period of time. But it's important to have this discussion with patients because the financial toxicity of long-term therapy can certainly be disabling in some patients. I think it's important for patients that are on ibrutinib that they continue to have routine follow-up with their oncology team. And so even though a patient may be taking the medication at home and may be doing well and responding well, there can still be toxicities that emerge. Fortunately, most side effects of ibrutinib will actually get better with time, but certainly even some chronic low-grade toxicities like diarrhea need to be discussed with your with the team, and because often these are toxicities that can be easily managed and the patient can remain on therapy. Where we sometimes run into issues is a patient may not necessarily disclose some of these toxicities, and then eventually it gets to the point where they feel that they can't take the medication anymore, where it may have been something that could have been intervened upon earlier in the course and the patient may have done just fine.